Hi, my name's Rachael and I'm an advanced care paramedic in the Queensland Ambulance Service. Today we've got doing this exemplar video on the failed intubation drill. The most important thing to understand about the failed intubation drill is it's an algorithm that allows a clinician to easily know what to follow and what to do in a dire, can't ventilate, can't intubate situation. I want to briefly talk about the importance of this before we go into the details of it. An example is in the Elaine Bromley case, which has been mentioned in studies prior, where basically our routine surgery went wrong, the patient was unable to be ventilated or intubated, and it resulted in a large delay in airway protection, which resulted in hypoxic injury and death. This algorithm is in line, the same reason we have a cardiac arrest algorithm, is to ensure that if that situation arises, our human factors and our stress levels can stay low and we can know exactly what we want to do. In QAS, CCPs, a standard CCP has the ability to cold intubate, which obviously doesn't carry as much risk as per an RSI. In Queensland, the HARU CCPs, which are skilled CCPs that get additional training and skills, are the only ones that perform an RSI. Every time an RSI is done, you are at risk of a can't intubate, can't ventilate situation, and therefore it's very important to brief your team on what will occur in steps as per the failed algorithm. So before I demonstrate this for you, we're going to go through those steps. So after we've had our first attempt at intubation, the most important thing to realise is that in QAS we have lots of little structured guidelines. So for example, in QAS we always use a bougie to increase our attempt of a first pass intubation, whereas in other services you don't have to use that first go. We always make sure we brief our team. Once we intubate the patient, we look at the monitor for CO2 waveforms. We're looking for 4 to 6 CO2 waveforms to tell us that we are in the correct location. If we do not get a CO2 waveform or not the waveform that we are looking for, we stop, we remove the tube, and we go to our failed intubation algorithm. We also allow 30 seconds or 2 attempts of an intubation before we enter our fail algorithm. And once the first attempt has failed, it's stipulated that the most senior clinician on scene with the most experience takes over. So in our situation where we've had an initial fail and we can't ventilate that patient, we attempt an oropharyngeal airway, bilateral nasopharyngeal airways, and a 2-person ventilation BVM technique. If that corrects it, then we have a reattempt looking at optimising our patient position and looking at laryngeal manipulation. If that doesn't succeed, we then obviously we're still having a can't ventilate situation, and we move on to the next step. In both cases, we go for our next backup airway, which is an LMA. If our LMA is able to ventilate, oxygenate the patient and has a good seal, then we manage as per the rest of the case, and we just continue with an LMA. If the LMA happens to fail, that is our indication to then go for a surgical airway. Surgical airway is a skill that is not done frequently pre-hospitally, but it's a skill that when you need to do it, must be fast-paced, and you must have gone through your failed intubation algorithm and be aware of what you need to do. For the purpose of this video, QAS, CCPs do not have surgical airway except for the HARU trained CCPs. As a result, we don't stock surgical airway kits at the stations available for use. So for the purpose of this video, I won't be able to demonstrate a surgical airway. If I can ask my airway assistant to come forward, we're going to go through a failed intubation drill.
Rach, I'm not getting any rise and fall.
No, we've got no CO2 waves, so let's take that tube out.
Okay.
We've got a failed intubation, guys. Then take that tube out. Then what I want you to do is pop an OP in for me.
Yep.
I'm going to pass you 2 nasos. They're already lubed up. I want you to pop those nasos in for me.
Sure.
And then I'm going to step in behind you. Now, in this situation, it's important to have the most senior clinical person with the most experience with airways to jump in, because we have one more attempt at intubation. Alright, I'm going to take over, Ben, if that's alright. Now, I'm going to do 2-handed technique. Can you take hold of the BVM for me? So, just going to ventilate at a normal rate for me. having trouble ventilating this patient. So at this point, we're attempting to pre-oxygenate. However, we're not getting very good ventilation. Here we go. Alright, so we're going to set up, we're going to continue oxygenating. Now Ben, what we're going to do is I'm going to have one more attempt. I'm going to use the size 7 again. I'm going to do laryngoscopy. You're going to pass me the bougie and then you're going to railroad the tube over for me.
Yep.
Now we've got our SpO2 back up to 98% and we're going to attempt this now, okay?
Okay.
Yep. Can you do burp for me please, Ben?
Yes.
Alright, I'm not getting a very good view here. I think that was the problem before. Alright.
What grade view?
At the moment a grade 3, Ben. Alright,
Yeah.
so what we're going to do, we're actually going to pull that out. I don't have a very good view. We're going to revert to oxygenation once again.
Yep.
Alright, Ben. I'm ventilating with an OP and bilateral nasos.
Yep.
Can you set up a size 4 LMA for me with 35 mils of air in the 50 ml syringe and lubricated? Getting our oxygenation up, our sats are improving. This is a very important task. We don't want to spend too much time on this.
LMS prepped.
Following the hard palate.
End-tidal CO2, beta
Perfect.
mask.
Alright. So with the LMA I'm looking for rise and fall of the chest, looking for fogging of the tube, which I've got, restitution of the tube. I would get my partner to auscultate for me, and I'm also looking at my CO2 and my SpO2.
Equal.
Brilliant. Alright Ben, thank you very much for assisting me.
Okay.
So that's a demonstration of a failed intubation drill, where the importance of understanding what steps you're going to take in a can't intubate, can't ventilate situation is of the utmost importance. To just reiterate to you, it's all about managing your airway with the resources that you have, using your oropharyngeals and your nasopharyngeals, a 2-person BVM technique as in the beginning, utilising your LMA and optimising your patient position, your position, using your bougie, and attempting to maximise this as much as possible, including laryngeal manipulation. At this point, if the LMA had been unsuccessful, we would have reverted to a surgical airway, and hesitation of a clinician to do that can result in the patient having hypoxic irreversible injury. I hope you found this video valuable and thank you for watching it.